This patient is a 74-year-old gentleman who underwent a colonoscopy which demonstrated a lesion in the proximal descending colon. The lesion was tattooed distally and biopsies confirmed an adenocarcinoma. Staging CT did not demonstrate any significant abnormality at the site of the primary tumor, and there was no evidence of metastatic disease. The patient was counseled for a laparoscopic extended right hemicolectomy with the possibility of proceeding to a left colectomy depending on the intraoperative findings. The optimal surgical approach for tumors arising at the splenic flexure or proximal descending colon remains a matter of debate. Available meta-analyses have not demonstrated any clear oncological superiority of an extended right hemicolectomy over a left colectomy. For a true proximal descending colon tumor, a left colectomy may be considered the more anatomical approach, particularly when the tumor and its lymphovascular drainage appears to follow the left colic branch of the inferior mesenteric artery. Nevertheless, an extended right hemicolectomy remains a valid oncological option, although it has not been shown to be superior. This video demonstrates some unexpected intraoperative findings and highlights how restoring normal anatomy can often help the surgeon navigate difficult situations and find a safe way forward during an operation. As soon as a laparoscope was inserted, the first finding was a large sigmoid loop almost in the configuration of a volvulus. The thickened mesentery suggested that this was a chronic condition and had probably been present intermittently for some time. Second finding was the presence of adhesions in the right iliac fossa from a previous appendicectomy. The first step was therefore to take down these adhesions and restore the normal anatomy of the colon. Once the volvulus was straightened, the tattoo was clearly seen at the apex of this large sigmoid loop. Clearly see the sigmoid colon and the distal bowel were dilated, presumably due to the intermittent obstruction at the point where the volvulus was repeatedly forming and resolving. Challenge number 2 was the dense wrapping of the greater omentum around the proximal and distal transverse colon and the splenic flexure area. These were clearly not ordinary adhesions. On reviewing the history, the patient had previously undergone cold snare removal of a benign polyp from the distal transverse colon. One possible explanation was an unrecognized microperforation at the time of polypectomy, resulting in this intense omental reaction which had effectively wrapped around and compacted this segment of colon. As you can see, the entire transverse colon was dilated. Our concern was that the tumor in the proximal descending colon might be causing obstruction. A tattoo, however, appeared much further distally in the sigmoid colon because of the large sigmoid volvulus, which had significantly distorted the normal anatomy. So once again, back to the basics. Restore the anatomy of the colon. Take all the adhesions and omental wrapping around the transverse colon to find out the cause of the dilatation. As you can clearly see, and as I mentioned earlier, these were not ordinary omental adhesions. The omentum was densely and completely wrapped around this segment of the transverse colon. At this point, our intention was not to take down the splenic flexure, as there was adequate length in the left colon. Our aim was simply to ensure that there was no large obstructing tumor in the distal transverse or proximal descending colon accounting for the dilatation. Once we were reasonably assured that there was no obstructing lesion in the splenic flexure region, we proceeded to take down the inferior mesenteric artery. Challenge number 3 was marked thickening of the peritoneum around the IMA, consistent with a chronic anatomical distortion demonstrated earlier. Please see my previous videos on sigmoid colectomy for the steps I normally use to identify and dissect the inferior mesenteric artery. In this case, however, the anatomy was significantly distorted. As you can see, up to this point, I was struggling to identify the IMA in its usual location because of the markedly thickened peritoneum, which could potentially have contained the vessel. Any attempt to divide this blindly could have resulted in catastrophic bleeding. This is where we went back to the basics, restoring the anatomy in order to identify the anatomical structures in their usual positions. After further dissection to restore the anatomy, we decided to change tack and dissect directly over the aorta with the aim of identifying the IMA in a retrograde fashion. Finally, a ray of hope. we identified a para-aortic lymph node stained with tattoo pigment from the previous colonic tattoo. This was sitting right on top of aorta, and we decided to remove it as this was not in the usual draining territory of the IMA. As shown by the yellow arrow, we could also see the origin of the IMA coming off the aorta. After we identified the left ureter, we were happy to cut the thickened band of the peritoneum, which originally behaved like a potential IMA site. A few more lymph nodes were identified at the origin of the IMA coming off the aorta. These are also removed. Eventually, the IMA was clipped and divided in the usual fashion. Again, back to the basics. The left colon was mobilized to join up with our previous mobilization of the transverse colon and splenic flexure, thereby restoring the normal anatomy so we can fully visualize the large sigmoid loop. Anastomosis was performed in the usual fashion and the leak test was negative. The specimen was opened immediately after the operation and the tumor was found directly at the level of the tattoo. Therefore, not only had the tattoo not been placed distal to the lesion, but it was also situated at the apex of a large sigmoid loop, which because of the distorted anatomy had been interpreted as being in the proximal descending colon. Postoperative pathology showed this to be a moderate and poorly differentiated adenocarcinoma, PT3, PN1A, or zero resection. 17 lymph nodes were identified. 2 of the lymph nodes were involved. The large apical aortic lymph node was not involved. 3 of the IMA lymph nodes were also not involved. The patient did very well and was discharged home on the 4th postoperative day. When faced with a difficult operative situation, restoring normal anatomy can often provide a safe way forward. I hope you found this video useful and I would appreciate your comments and questions.